Iraq, and the USA. The purpose of this program is to share the expertise and knowledge from the West to radiology around the world. We broadcast live radiology webinar on the first and the third Sunday of the month, and there's no cost to join. I would like to thank IT team from Vietnam who is taking care of the broadcast, and Indonesian team for taking care of the flyers and the newsletter. And today we are moving toward the end of the neuroradiology. This session is almost the last session. The following session will be the last session. And now I would like to welcome everyone to this webinar and would like to pass on this task to Dr. Win, who is a neuroradiologist from Bachmai Hospital in Hanoi. He is our moderator today. And Dr. Win, please.
Okay, thank you, Dr. Tiffany. Hello, everyone. My name is Quang Anh, interventional neuroradiology in Bachmai Hospital in Vietnam. And it's my pleasure to be with all of you in AREP lecture in this nice weekend. Today, we will listen and learn a very wonderful lecture. And as Dr. Tiffany mentioned, let me introduce our guest speaker today, Associate Professor Patrick Brown from Wake Forest University School of Medicine. He's Associate Professor of both Radiology and Neurosurgery, and he's very experienced in brain and spinal vascular malformation. Dr. Brown graduated from University of Arkansas College of Medicine. Then he completed his intern in Missouri, his resident in Boston, and both fellow of neuroradiology and interventional neuroradiology in Duke University of North Carolina. He's now Associate Professor of Wake Forest School of Medicine from 2019 to now. He already took part in many projects with the author of more than 20 articles and 5 books, and he also gives many lectures in many conferences all over the world every year. Professor Brown, please.
Hi, thanks so much. Appreciate you all inviting me to do this. So hopefully we get a lot of questions. That's the point. And so let's get started. I'm gonna share this, see if it works. Can everybody see that okay?
Yes, we can see that.
Perfect.
Yes.
Perfect. Great. Okay, so we're going to talk about cerebrovascular malformations, and this really is a very high sort of top level view. We are going to get into some of the details and some of the more interventional aspects of it because that's what I do. But hopefully we really just get a good survey of all of the different things that you might encounter in daily practice as well. Let's see. I have no relevant disclosures. Oh, also, this is Stone Mountain, North Carolina. It's a beautiful, it's really a beautiful park in the western part of our state. So anyway, I don't have any relevant disclosures for this talk. Let's get right into it. So brain vascular malformations. Taking a step back, the initial plan for this talk was to do brain and spine, but as I put this talk together, I realized that there was just too much material to cover in the allotted time to do both. So we're probably going to be doing spine in a different session. So this is all going to be focused on brain or cerebrovascular. But when I look at brain vascular malformations, or really any vascular malformations, I think of them in terms of really two different categories. Are they high flow or low flow? High flow vascular malformations are typically associated with a shunt, and we're going to talk about what a shunt means, but just to preliminarily, that means that blood flow is going from an arterial source into a venous structure without an intervening capillary bed. And so if you can imagine the capillaries, the job of the capillary bed is to allow for nutrient exchange and oxygen and CO2, but it also sort of decreases the pressure flow from artery into vein. And so when you have these high flow lesions, this shunting produces pressurization of the venous side of the system, which can lead to some problems. So in those, we're going to be talking about arteriovenous malformation, or AVM, and arteriovenous fistula, or AVF. AVF is technically not a malformation, but it's sort of adjacent to all this, and it's clinically relevant. So then the low flow vascular malformations are cavernous malformations, capillary telangiectasia, and developmental venous anomaly. Now, for those of us who are doing more imaging than intervention, these three are the ones that you're probably going to encounter more frequently than the high flow lesions. And then I put a little unusual one, a pure arterial malformation, which is, we'll talk a little bit about that. So starting right off with low flow malformations, the first one we'll talk about is a cavernous malformation, or cavernous angioma. These are incidental findings. You'll see them on MRI most frequently. They can be occult on CT, so you may not see it on a CT scan. Occasionally, you might see a little bit of a focus of, or focal area of hyperattenuation in a region where you may suspect a cavernoma, but you often will not see it on a CT scan. Again, often incidental. They can produce symptoms, so people can have headaches. That's usually associated with some episode of bleeding, seizures, or focal neurologic deficits. So, I think like focal neurologic deficits, I think probably are related to seizure when they're, cortically based, but sometimes they can be in the brain stem as well. On MRI, what you will see is mixed signal intensity. Areas of hyper intensity on T2, hypo intensity, and similar on T1 weighted imaging. Sort of a mixed hypo intense signal. They tend to be very circumscribed, and on T2 star imaging or GRE or SWI, they will show regions of susceptibility or blooming artifact. Importantly, if you were to do a catheter angiogram to look for a cavernoma, you're not going to see it. They're angiographically occult. If you do very, very delayed phase angiographic images, you may see a little bit of filling into one of them, but these are occult lesions. So so what we have here, I don't know, are you able to see my pointer when I point, or no?
Yes, we see.
Yes.
Okay, great. So what we have here on the left is a T2 weighted axial image, and you see that sort of mixed signal intensity, what they call a mulberry lesion. So if you imagine a little berry there with its little individual little seeds, that's kind of what we're looking at. And then when we move over here to a GRE sequence, you see that area of blooming. And then on the post contrast, you notice that there's not a lot of enhancement within this cavernoma. Sometimes they can enhance pretty well on delayed phase imaging. But the thing that I really wanted to point out is this structure, which we're going to talk about in a minute, which is a developmental venous anomaly, or a DVA, and they're very frequently associated with cavernoma. So it's something to look for. Next low flow lesion that I want to talk about is capillary telangiectasia. This is the most common cerebrovascular anomaly aside from a DVA. Again, these are often incidental. They very rarely are going to produce any kind of symptoms. The main thing that you need to be aware of is that you don't want to call one of these a tumor or a glioma, because that can obviously cause, that can produce an unnecessary surgery for a patient. And what they consist of is sort of dilated capillaries that are sort of interspersed with normal brain parenchyma, as opposed to a cavernoma, which there is no normal brain parenchyma, within the malformation. Most frequently, you're going to see them in the pons, cerebellum, and spinal cord. The one that we're showing here just happens to involve the temporal lobe, and they're going to be, ISO intense on T1 and T2 weighted imaging. Sometimes you can get some hypo intensity on T1 or hyper intensity on T2, but most of the time they're going to be ISO intense. But on T2 star imaging, you're going to see this blooming artifact or susceptibility, and they're going to enhance. That's the thing. You'll see this sort of circumscribed area of an enhancement that coincides with the blooming artifact. And in those cases, you definitely would not want to call that a tumor. So that's that one. Then low flow malformation, the DVA. All right, so a DVA is basically an altered drainage pathway from so normally your venous structures are gonna drain out into progressively larger veins and then out into the dural venous sinus. And what you have with a DVA is these veins within the brain are collecting into one sort of larger venous channel that is then draining out directly into an ependymal vein or a dural venous sinus. And they can cause some problems if that draining vein were to be occluded. That can produce a venous infarct. They can show up with hemorrhage there. The hemorrhage can also be associated with a cavernoma that is nearby the DVA. The majority of these are going to be asymptomatic or incidental. They're usually solitary. If you get multiple ones, you can consider a syndromic presentation. The classic one that people talk about is blue rubber bleb nevus syndrome. I don't know that I've ever actually seen that in practice, but you'll see it on tests and things. What this looks like, there's the description of a palm tree appearance or Medusa head appearance. So I think that this one sort of shows you that palm tree morphology. Similarly here, you can sort of imagine a palm tree there. But again, you frequently won't see these on CT. Every once in a while, you may see some of the slow flowing blood showing up as a region of relative hyperattenuation that's going to be roughly iso-attenuating to the dural venous sinuses. All right. And then pure arterial malformations, these are pretty rare. They're probably a benign entity, but they look really ugly. And essentially what these are just these dilated, tortuous, sort of looped arterial structures. But importantly, you won't see any evidence of shunting. And these look to me like aneurysms or maybe even fibromuscular dysplasia if they were going to be outside the head. But as far as we know, these are probably benign, and we leave them alone. I think most of the time, if you were going to see one of these on a cross-sectional imaging study, you're probably going to recommend an angiogram to get a better look at it, though. So let's move on to the high flow lesions, and let's talk about brain arteriovenous malformations. So this is just a T2 axial image through the brain showing a collection of dilated channels, and hopefully by the end of this discussion, you'll be able to characterize that in a more efficient way and make some appropriate recommendations. Brain AVMs are often incidental. So probably the most common way to pick them up is incidental. They're pretty rare in the population, but they can present with symptoms. Probably the thing that we think about the most, the thing we worry about the most is hemorrhage. It's predicted that they bleed about 2 or 3% per year. So a 2 to 3% chance of bleeding per year for just your general arteriovenous malformation. If they're a higher grade, then probably more of a risk for bleeding, but that's sort of the average across all AVMs. They can present with headache or seizure or other neurologic deficits. And basically what they are, they're this shunt lesion that's composed of a feeding artery or arteries going into a nidus, which is this, as you're looking here, this collection of abnormal vascular channels where there's no capillary bed, there's no nutrient exchange, anything like that happening, and then going into a draining vein or sometimes multiple draining veins. Again, usually you're only seeing one in a patient. If there's multiple, you should consider a syndrome, consider a syndromic presentation like hereditary hemorrhagic telangiectasia. But in this case here, what we're seeing is, again, that same axial T2 weighted image of the brain with a large vascular nidus within the right temporoparietal region in the right lateral ventricle. This is a AP and lateral catheter angiogram demonstrating arterial enhancement with a very diffuse or irregular amount nidal enhancement being supplied by these branches, the right MCA. The AVM nidus can be classified as compact or diffuse. So compact nidus is going to be a very discrete, often rounded appearance, where a diffuse nidus sort of looks like this one, where it's kind of all over the place. There's abnormal enhancement all over the, sort of in a very wispy pattern, and it's very hard to, it's very challenging to measure a diffuse nidus because you can't see where the nidus stops and where regular brain starts. Spetzler-Martin grading, you will see this. This is really more of a grading of surgical morbidity for excision or treatment of these lesions. And it depends on size, eloquence, and venous drainage. So it's on a grading system or a grading scale of 1 through 5, and you get a point for each of these things, depending on the size. If this concept of eloquent versus non-eloquent brain, I think that's up for debate. I believe that if it's an area of brain that's going to produce a neurologic deficit when it's lesioned, then that's probably eloquent brain. And but some people will call things like the right frontal lobe non-eloquent. So that's a debatable question. And then in terms of venous drainage, we look at deep versus superficial. So deep venous drainage portends a worse prognosis for these things because the vein's harder to get to surgically. And also, if you were to occlude a deep vein inappropriately, then that tends to cause a worse neurologic outcome than that of a superficial vein. On cross-sectional imaging, again, head CT, you may not see it. It may be occult, but sometimes you can catch some of, if they have a very large draining vein, you may see the draining vein similar to what we saw on the DVA, where it would be iso-attenuating to the dural sinuses. But when on symptomatic presentations, often we'll see hemorrhage or edema. But when you do a CT angiogram on these, you very frequently are going to see the nidus, particularly when it's large. And then you'll see the feeding artery and draining vein opacify. The feeding artery, it tends to be asymmetrically enlarged, and then the draining vein is usually pretty obvious when it's big. In the setting of hemorrhage, if it's a small lesion, with a hematoma there, that nidus could be compressed, and that may make it occult on non-invasive imaging. So what we're seeing here is an axial non-contrast head CT, and you can just catch the suggestion of a tubular structure in the left mesial temporal lobe. There's maybe a little bit of surrounding edema here. Again, you don't always see that, but this is a pretty large draining vein. And then on CT angiography, this is an axial and a coronal reformatted image, and what you're seeing is this large amount of nidal opacification with a draining vein. On MRI, this is the same AVM. Flow voids. T2 weighted imaging is really sort of a workhorse for me to look for these things. You want to see those flow voids. So what creates a flow void is fast flowing blood, and so in these in an AVM nidus, the blood is flowing quickly. So you will see those dark flow voids on T2 weighted imaging. Pulsation artifact can be useful. So if it's in the phase encoding direction and you're seeing, phase artifact there, then it would suggest that this is pulsatile or fast flowing blood. Again, hemorrhage and edema and mass effect are things that you're looking for on the MRI. I want to point out here on T2 star weighted imaging that you see these regions of relative hypointensity or blooming artifact. And these probably represent sort of subclinical hemorrhagic events. So this AVM is probably bled a little bit, even though this was, what we would consider, presenting incidentally in this case. Post-contrast imaging, again, the spin echo sequences I think are less useful. I prefer to look at SPGR, the spoiled gradient echo sequences for looking at nidal opacification and venous structures, just because the spin echo sequences tend to be a little bit more susceptible to the pulsation artifact, and they don't for me, they don't show the contrast enhancement as well as I would like. So when you're looking at these things on a non-invasive imaging study, do you see a nidus? Okay, and then describe that nidus in terms of size, shape, location, morphology. Look for inflow. What's the inflow artery? If you can tell what it is, you should probably describe it. And then look for the outflow. Is it deep or superficial? And then look for things like aneurysms. So look for aneurysms of the feeding artery. Look for aneurysms within the nidus, and then look for outflow aneurysms. So venous aneurysms or varices, or if there's any evidence of a stenosis of the outflow, because those things are going to be the things that portend a higher risk for bleeding. So any kind of aneurysmal dilatation or outflow stenosis is going to suggest that this thing may be at a higher risk for bleeding. So pretty much any brain AVM that's picked up is going to get a catheter angiogram, because you do want to get a better look at the angio architecture of the lesion. So again, we're on an angiogram, we're looking for a shunt, right? So we're looking for arterial blood flow in the same picture with venous blood flow. If you see that, that suggests that this is a lesion that's shunting. So it is a high flow lesion. Again, when you're doing a catheter angiogram, same thing. You're looking at nidus, size, location, shape. Are there any associated aneurysms within the nidus? You're looking for the inflow artery or arteries. Are there any associated feeding artery aneurysms? And then you're assessing the outflow. Is it deep? Is it superficial? Is this a variceal draining vein? And then finally, is there any flow limitation or stenosis on the outflow? So outflow limitation, the reason that suggests that there's a higher risk for bleeding is just because you've got persistent inflow, and if the blood can't get out at the same rate that the blood is getting in, then that AVM is at risk for bleeding. So this is just an imaging case. So we have an axial T1 or SPGR post-contrast sequence, and we're seeing a rounded area of abnormal enhancement, and that's all that we saw in this study. There was no other abnormality, but that was suggestive of a possible AVM or vascular lesion. So the patient went for catheter angiography. This is an AP and lateral, and these are all sort of magnified to try to show you the relevant anatomy. We didn't just show the whole. I didn't show the whole picture. But what we're seeing is a focal compact nidus up here in the high, right parietal lobe, fed by an enlarged right MCA branch with a draining vein going into the superficial going into, a superficial draining vein going into the superior sagittal sinus. And you're seeing that all in the same picture. So that suggests they're shunting, right? And so that would be probably a Spetzler-Martin grade 1 or 2 AVM, depending on whether you thought that this was eloquent or non-eloquent cortex. Here's another case. This one was a symptomatic presentation. So you have an axial CT head with hemorrhage here in the fourth ventricle, probably a little bit of parenchymal hemorrhage as well. And that, that basically prompted us to do a catheter angiogram. And what we're seeing here is this is a right vertebral artery run. So we got an enlarged basilar artery, definitely some enlarged superior cerebellar artery and anterior inferior cerebellar artery, all supplying this nidus. This nidus is mostly infratentorial and diffuse in appearance. So the PCA generally does not supply infratentorial structures, but I think that there's probably some enlargement of this PCA. There may be some PCA supply as well. So multiple arteries are supplying this lesion. It is a diffuse nidus. It would be hard to draw, a circle around where the nidus starts and where it stops. Then you have a large draining vein with an associated varix and deep drainage. And so this is a high grade, difficult AVM, is difficult to treat, and also it ruptured as expected because of its morphology. So what do we do for treatment? There are a lot of different ways to manage these things. And we'll talk about the things that are relevant to interventional. First thing is observation. So observation is a treatment. Just because you're not putting a catheter into it, just because you're not doing an embolization, that doesn't mean you're not treating the patient. So there's a pretty important paper that people like me would refer to. The trial was called the Aruba trial. And basically what it was a prospective randomized study looking at medical management versus interventional and surgical management for patients with incidental or unruptured brain AVM. Took the total 226 patients were randomized into this study, and it was stopped at an interim analysis because medical management was so favorable in comparison to intervention. The hazard ratio for stroke or death after intervention versus medical management was 3.7. So pretty significant difference there. Spontaneous rupture rate in these, this is where we got our sort of idea of what spontaneous rupture rate is for these. Is probably around 2.2%. So 2 to 3% per year is what we anticipate for brain AVMs. So based on this study, what probably most interventionalists and surgeons will do is they'll observe or treat expectantly for unruptured brain AVM. But what about the ones that you are going to treat? So let's pretend that they've hemorrhaged, or they're presenting symptomatically in some way, like with seizure or focal deficits. So if you're talking about endovascular treatment, I like to think of it in two flavors. It's either curative or targeted. So a curative embolization is going to be a situation where, this is an AVM that's ruptured or is symptomatic in some way, and you need to get the entire thing out. That's going to require some kind of combined approach. Very, very, very rarely are you going to be able to achieve a curative embolization with catheter-based techniques. There are some people doing these things out there, but I think that the vast majority of people are going to require either embolization with surgery or embolization with radiation. But you're almost never going to cure an AVM with a catheter. So a targeted treatment however, is something that you certainly can do, with just endovascular techniques. And so what we do with a targeted treatment is if we see some of those high risk features like a nidal aneurysm or a feeding artery aneurysm, then those are things that we're going to try to treat with catheter-based techniques with coil embolization or liquid embolic agents to try to modify the rupture risk for that patient. We can't eliminate the rupture risk, but we're going to try to reduce it. And so here's a case of a ruptured brain AVM. So this is a head CT with intraventricular hemorrhage. And on the CT angiogram, we see a large right-sided brain AVM. Bring the patient for an angiogram, and this is what we see. We see a large, nidus supplied by multiple MCA branches as well as anterior cerebral artery or ACA branches. We navigate up into the AVM a little, or subselectively get a little bit further out, and we're able to do additional imaging. And what we see here is this structure hanging out in what was the right lateral ventricle. And that's a nidal aneurysm. So this is an AVM that is ruptured, but has a high-risk feature. So this high-risk feature is this nidal aneurysm, and that appeared to be what was probably the rupture point. So decided to try to go out and definitively manage that portion of the AVM. So navigated a microcatheter out into the relevant anatomy and injected this material here, which is onyx, or it's a ethylene vinyl alcohol. It is a liquid embolic agent. And we're able to close off the branch supplying that portion of the AVM. And this is post embolization angiogram showing, there's the onyx cast in the relevant anatomy, and then that nidal aneurysm is no longer opacified. This is the post-intervention head CT, and this is what the onyx material looks like on CT. Here's a rare example of a curative embolization for an AVM. This is a patient, again, who presented with rupture. There's a large left parietal hematoma. And the CT angiogram was negative for a causative lesion, but this was a young patient without other risk factors, no hypertension or anything like that. So we took the patient for an angiogram, and sure enough, this is a very small a focus of nidal opacification coming off an MCA branch with a draining vein into the superior sagittal sinus. So we navigated a microcatheter out to it, confirmed that lesion. Again, this is the draining vein going up into the sinus, and we see this really wispy small focus of enhancement. It's very unusual for someone with such a small AVM to rupture, but nonetheless, it happened in this case. So again, I was able to get some liquid embolic into that lesion, and the follow-up angiogram showed that there was no shunting left, so the AVM was gone. And I think at a lesion that small, you may actually be able to get a curative embolization in a single session. Typically, I would be a little bit nervous about going out into an MCA branch and injecting liquid embolic. But in this case, the patient already had a pretty large hematoma in the area. So the likelihood of causing additional symptomatic stroke is pretty low given the presence of the damaged tissue already in the region. So surgical treatment. I don't do this. So, but this guy does. This is one of my partners. This is Dr. Wilson. So he and I and several of the other neurosurgeons work together pretty closely in managing these patients. I won't go very much into surgical treatment because I don't do that and don't have much expertise in it. But basically, what you want to be able to do is disconnect the arterial supply to the AVM sequentially and isolate the AVM from any arterial supply, and then occlude the vein. The last thing you want to do is occlude the vein. If you occlude the vein first, again, you basically create an outflow stenosis, and that AVM can rupture. Again, these are going to often be combined with other techniques, embolization, radiation therapy. So treatment of brain AVM is really usually multimodal. Radiation. So let's talk a little bit about radiation. So these people are our friends. When we have a brain AVM that's just very high risk, or for embolization or surgery, or potential, or if it's not high risk but incidental, and we don't really want to operate on it, but we think the patient may benefit from a form of treatment, then we'll often engage these folks. So this is so the person I'm really focusing in on is Dr. Tatter here. He's one of my colleagues in the neurosurgery department, and he and several other people work together for this for radiation therapy. So this is stereotactic radiosurgery, and what we have here is gamma knife. Here he is again. These are really old slides, so they've been doing it for a while here, and this is the team sort of currently. It's a big operation, and they work really well with us together. So this is Dr. Tatter now. This is Dr. Laxton, and this is Dr. Chan. And so what this is gamma knife stereotactic radiosurgery. We use cobalt-60 as a source of gamma rays, and then we use stereotactic navigation to help direct those gamma rays into a target. In this case, we're talking about arteriovenous malformations. It's usually delivered in one single session. The important thing is to remember with this is that it's a delayed response. So it usually takes, we usually don't follow up with these patients again for 3 years after they receive the radiation therapy. So they'll get a treatment, and then we'll do a follow-up angiogram in 3 years to see how they did. So here's a case where we did stereotactic radiosurgery. So this is a large, we've seen this picture before. It's a large incidental AVM within the right lateral ventricle. So trying to embolize this thing, trying to resect this thing surgically, all of those things are going to be pretty morbid things to do for this patient, and likely to create some substantial deficits. This is the catheter angiogram for this patient. So what we do is we take them and we place them in a stereotactic head frame. So you can see these are actually screws that are screwed into the skull. And it holds this frame in place so that the navigation can use these little X's and pluses to localize the area of interest. So what we're doing in this case is localizing this portion of the AVM, this inferior portion here. And this was an angiogram taken in 2019. In 2020, we brought the patient back, and what you see is that portion of the AVM that was targeted is now gone, but there's still this portion up here. So the patient got an additional treatment because this was such a large lesion. And so then if we fast forward to 2023, this is what the brain MRI looks like now. So there's, really no abnormal nidal opacification. There's some edema, probably post-treatment change, but we don't really see any large, flow voids or anything like that. So this is a very good outcome. So either a complete or near complete response from radiosurgery. So this patient almost certainly had a drastic reduction in their lifetime bleeding risk by doing this. We're going to switch gears here. We're going to move over to dural arteriovenous fistula. So this is another high flow vascular lesion that is not a malformation, but is sort of malformation adjacent, and will often be discussed, kind of simultaneous with brain AVM. So what a dural arteriovenous fistula is comprised of is, again, a shunt lesion where arterial blood flow is going directly into a vein without an intervening capillary bed, but in this case, there's not a nidus. So no nidal opacification. This is a head CT that we're going to look at a little bit later. But so these lesions will, again, they can be asymptomatic, but they're usually picked up when patients come in with complaints of pulsatile tinnitus. So they'll hear a whooshing or swooshing sound in their ear. They can present with headache or seizure. When the fistula involves the cavernous sinus, it can produce some specific cavernous sinus syndromes that can cause eye pain, proptosis, or problems with extraocular muscle movement. Again, composed of a feeding artery. Importantly, in these cases, the feeding artery is extradural, so it's often going to come off a branch of the external carotid artery or the vertebral artery before it enters the head. There's a fistulous connection to an intracranial draining vein without a nidus. And so in this case, what you're seeing are branches of the occipital artery going to supply the sort of wispy, small arterial structures, which then drain directly into a dilated draining vein. These are acquired. This is not something you're born with. They usually are the result of trauma, or we think also probably the most common way is that if a dural venous sinus is thrombosed and then spontaneously revascularizes. So when you're classifying these things, it's kind of similar to brain AVM. You want to say where it is, but then you definitely are going to be on your angiogram. You're going to be looking at direction of flow and how the venous drainage pattern looks. There are some pretty complex classification systems. The two that are most commonly used are Conyard and Borden, and essentially what you're looking for in these is what's the directionality of flow in the vein, and is the vein enlarged or aneurysmal. So the higher grade lesions portend a higher risk of bleeding, and in those cases the blood flow is going through the artery into the vein, and then it's refluxing into the vein before then draining out of the head. If normal antegrade flow of venous blood is preserved, then that is typically a pretty low risk lesion, and it may be one that we would observe. Whereas if you see, retrograde or reflux flow into a venous structure, or if it's draining directly into a cortical vein, and particularly if that cortical vein has a varix or aneurysm, then those are high risk lesions, and we're probably going to recommend treatment. On CT, you're often not going to see these on a non-contrast study. They can, again, present with hemorrhage and edema, and that will often be your secondary sign that something's going on. On CT angiography, they also may be occult. If they don't have a large draining vein, you may not see it. If it's just draining directly into the sinus, you might not see it. So in patients who come in with a complaint of pulsatile tinnitus and the CT angiogram doesn't demonstrate the lesion, I'm often going to recommend a catheter angiogram to further assess, because the CTA just will miss some of these. But if they're obvious, what you're going to see are enlarged cortical veins. You can see the external carotid feeding arteries. If they're asymmetrically enlarged in comparison to from one side to the other, then those can be cases that you could predict a presence of a fistula. So here's an example. This is a patient who came in with a complaint of facial pain, actually. Got several CT studies, all of which were negative, and finally, somebody thought let's just check a catheter angiogram and take a look. And sure enough, there was a fistula. So this is this little wispy stuff here is the fistulous connection, and here are your enlarged external carotid branches, and then venous drainage directly into the sinus. This is a case where we actually did pick something up on non-invasive imaging, and and then recommended a catheter angiogram. So this is a patient who had a brain MRI performed for another reason, but out here in the left sylvian fissure and along the surface of the left temporal lobe, we're seeing these sort of enlarged vascular structures. Now, that would be, it's not uncommon to see asymmetry of, the vein of Lebet or the, Trillard. That's not uncommon at all. But when you see this pulsation artifact across it, that really should make you concerned that this may be a fistula. And in this case, we recommended a catheter angiogram, and it did demonstrate a fistula. This is a high-grade fistula here that's high risk for rupture. So you're seeing opacification from the right, or from the middle meningeal artery into this fistulous connection, directly draining into a cortical vein, which is enlarged and variceal. So this is a high-risk lesion. So again, we've sort of discussed how we would, this, just kind of a checklist. Look for a shunt. Where is the shunt? Is it going into a sinus or a cortical vein or both? What's the inflow artery? And then what's the directionality of flow? And finally, if you do see flow into a cortical vein, is there ectasia or aneurysm or varix? So treatment. First of all, does anybody, you can just put it in the chat. Does anybody know what this is? This is one of the most beautiful places in the world, I think. This is in Scotland. This is the Old Man of Storr. It's on the Isle of Skye. So if anybody ever has opportunity to go there, I think this is probably the prettiest picture I've ever taken. But anyway, so treatment for dural AV fistula is similar to that for AVM, with the exception that in dural arteriovenous fistula treatment, catheter-based techniques can be curative. So endovascular treatment is the mainstay for a lot of these lesions. You can treat with surgery or radiation, but again, catheter-based intervention is often going to be the treatment that can be definitive. If you can close the fistula, you can cure the patient. This is a case where we intervened with a catheter. Patient presented with headache, loss of consciousness. There's a posterior fossa parenchymal hematoma and interventricular hemorrhage. CT angiography demonstrates a large, midline draining or midline vascular channel, highly suspicious for presence of a dural fistula, because we don't see a nidus in this picture, but you still see that big draining vein. If you don't see the nidus, but you see a big draining vein, you should be thinking fistula. Bring the patient for angiography, and we've already seen this angiogram, but here's the, what it looks like. We've already discussed it, occipital artery supply, fistula, large draining vein with associated varix. This is a high risk lesion, and it in fact has already bled. So how do we treat it? We're going to try to embolize it. So we go up, we get subselective into the occipital artery supply. We do a subselective run. We're identifying the fistula a little bit better here. We navigate as close as we can to the fistula, and then we inject our embolic agent. In this case, it was onyx again, and this is a large onyx cast. This is a big fistula. This is a big embolization. This is the post-embolization control run, and we see no residual shunting. This was an angiographic cure of a large ruptured AV fistula. Here's what the head CT looks like on follow-up, so you can see that big onyx cast. Another case, this was that incidental case that we showed earlier. So you've already seen this middle meningeal artery supplying in a fistula, big draining vein. So navigate a microcatheter out. The trick is to get as close as you possibly can to the fistula, or even get inside the fistula if possible with your microcatheter. And once you get there, then you start injecting your embolic agent. There's some subtleties to how you do that, probably beyond the scope of this talk, but basically get into the fistula. If you can get embolic agent on the arterial and the venous side of the fistula, then you have a good chance to achieve a cure. And in this case, that's what we were able to do. And here's your control run with no residual shunting. This is what the onyx looks like post-intervention. Here's a case. This is Dr. Tatter gave me this case. I did not do this intervention, but he gave me this case. This is a case that they treated with radiation. So combined treatment does happen. Surgical treatment does happen for these. But in this case, the patient got embolization and radiation. So presenting with facial pain, patient had the operator in this case was not able to get into the fistula. It's such a diffuse lesion. They were really unable to get there. So they did a lot of embolization of the proximal arteries. So coil embolization of proximal vessel can slow flow down, but it often will not cure the lesion. And that's exactly what happened in this case. So the patient then went for stereotactic radiosurgery. There's our friend, Dr. Tatter. And then, so that was in 2019 when they got localized for stereotactic radiosurgery. Here's a follow-up angiogram in 2024 with complete resolution of the abnormal shunting. Couple special cases here at the end. So this is an example of trauma. So we're in the United States, so we have to talk about gunshot wounds. And this is a case of a young patient who was unfortunately shot in the neck and transected the left vertebral artery, but in the process created a traumatic arteriovenous fistula between the left vertebral artery and the vertebral venous plexus, draining down into the internal jugular vein. So this case was a true emergency. The patient was not bleeding to death or anything like that, but this is an important demonstration of how this shunting can affect the rest of the blood flow. So this is a right vertebral artery injection, and you see blood flow going up the right vertebral artery and back down the left vertebral artery to fill this fast shunt, fast fistula. I injected the left side, and the left vertebral artery is transected proximally. So the only way to access this fistula is from going across the basilar and back down. But what you notice here is that there's no opacification of the basilar artery distally. So all of this blood is just being sucked back down into this fistula. And so what can happen over time is that as this fistula develops, the patient can develop vertebrobasilar insufficiency, and they can have a stroke. So what we did, I took a catheter up and over the basilar artery, and you can see where I injected here to show the fistula. Again, get as close as you can to the fistula or get into the fistula if possible. And in this case, I used embolic coils, which you can just see here. And the reason I chose to do that is because I did not want to inject a bunch of onyx directly into this fistula and have it go out into the lungs by draining down through the vein. So I wanted to really control the embolic agent, and coils allow you to do that. So a loop of coil did get into the venous side, which is what we wanted, and then I occluded the arterial side with additional coils. Here's the culprit bullet, by the way, right here. But then we did a post intervention run, nice brisk forward flow. That fistulous connection is resolved, and now you see the basilar artery getting blood flow the way that it should again. Last case. This is a case, a really challenging case. This is and these always show up at 2 or 3 o'clock in the morning, and that's the way this one came. This is a patient who had horrible, painful proptosis of the right eye. The orbit is edematous, and the optic nerve is stretched, and the patient was losing vision. So this is a true emergency. The patient's going to be blinded if we don't do something. You see, this is a time of flight MR angiogram, and this is sort of the normal cavernous carotid on the left, and here on the right, what you're seeing is arterialized blood flow in the cavernous sinus. So this is a carotid cavernous fistula. Brought the patient for angiography and demonstrated a direct fistulous connection, probably for diagnostic radiology purposes. Discussion of subtypes of carotid cavernous fistulas beyond the scope. But essentially, you can have direct versus indirect fistula. A direct fistula is going to be a hole in the cavernous carotid artery that is filling the cavernous sinus, whereas an indirect is going to be some branches of other vessels going into the cavernous sinus through a fistulous connection. But in this case, there's a hole in the artery, and it's just pressurizing this cavernous sinus with arterialized blood and producing some pretty considerable symptoms. These are very difficult to treat. The most sort of the classic way to do it is to use embolic coils to try to occlude the cavernous sinus and force blood to go back up through the carotid in the normal pathway. I put a lot of coils into it, but still could not occlude it, couldn't get it to work. I called my partner, Dr. Wolf, who came in to help me out with this case early in the morning on a weekend, and we put a series of stents to try to help relieve this, and eventually did improve it. Did not totally cure it, but we did improve it. So you can see that the blood flow is improved there. The sinus opacification is decreased. And then the patient did end up doing better, regained eyesight, and the orbit normalized over time. So these are very challenging cases sometimes. As I alluded to already, this is a team effort. That you can't do these things without partners. So this is our team. This is Dr. Wolf. She's now the chair of neurosurgery here, and she's a neurosurgeon who does endovascular. This is Dr. Farjan. He's a neurosurgeon who does endovascular. This is our new partner, Dr. Khanna, who is also a neurosurgeon and does endovascular as well. And I'm the radiology component of the team. And then this is Dr. Wilson, who I'd already talked to you about earlier. So I appreciate you, listening in, and hopefully you learned a little bit, and welcome any questions.
Okay, thank you so much, Professor Brown. If you have any question, please type in the Q&A in the chat message. I will have you to ask some question regarding to the approach to the vascular malformation of the brains. And in the lectures, we know how to approach. That's we will divide the two groups. The first is a slow flow with a very low rate of the hematomes. The second group is a high flow with the malformation, the AVM, and the durophysin, which is very difficult. So first we have two questions for the slow flow group. The first one from the audience, that's he want to ask, how about the pure arterial malformation? Do we need to treat it? Because as you mentioned, it's rare and benign.
Right.
The second question from me, that I want to know that's about the developmental venous anomalies. It's very rare and very low risk of rupture. Have you seen any case that a DVA develops into the intracranial hematome, especially the DVA in the posterior fossa? Thanks.
Yeah, so the pure arterial malformations, again, they're really rare. We don't have very many cases of those. We think they're benign, and therefore probably should not be intervening on them. We'll often do it. You would do an angiogram for it usually, because if you see one on a CT angiogram, for example, you may not be able to tell exactly what it is until you do a catheter angiogram. So that case that I showed earlier, you would imagine on a CT angiogram that probably did look like an aneurysm or an arteriovenous malformation. So usually you're going to do an angiogram, but if you can confirm there's no shunting and there's that this looks like one of these pure arterial malformations, it's probably going to be an observation. And then the second question about DVA, I've never seen a DVA hemorrhage. I know that there are cases where you had thrombosis of the draining channel, and that would result in, that could produce a venous infarct. And venous infarcts are often hemorrhage, but I don't know that I've ever seen one primarily bleed. The Where I have seen hemorrhage associated with the DVA, it's almost always been the cavernoma that's associated with the DVA that bled, because we know cavernoma and DVA often go together. And we think that there may be some developmental reason for that, that there was the cavernoma developed, and then there was the normal venous channels that would drain that portion of the brain didn't develop the right way. And so that the DVA is we think maybe a result of that sort of abnormal development of the vein from the cavernoma. So again, in summary, I guess most, if not all, of the hemorrhages that I've seen associated with the DVA have been the cavernoma bleeding. And then
Okay.
to go a step further, if you do, in my practice at least, if I have a patient who's got a parenchymal hemorrhage, and the MRI shows a developmental venous anomaly near the hemorrhage, I will often tell people that it's probably a cavernoma associated with the DVA that bled, and so we probably won't even do a catheter angiogram to look at that case, because we know we're not going to see anything.
Okay, doctor, thank you so much. Another question from the audience is as how do we know that the cavernoma which is hemorrhaging and cause the clinical features? Maybe he's meaning that because in the MRIs you see the cavernoma is a very low density in the T2 star, but how can we know it's the active bleeding? Thanks.
Yeah, well, I mean, so that's a great question, and a lot of these are going to be, so if somebody has a cavernoma and they've been having headaches, it could be that the cavernoma is bleeding a little bit, right? It's not a big, expansile hematoma, but sort of small volume bleeding at a low rate, which is then stopping and starting and stopping. So that's absolutely possible. And in some cases, if a patient has a cavernoma that could plausibly be producing these types of symptoms, those are lesions that would be resected potentially. I've also seen people do radiation for cavernoma, or stereotactic radiosurgery, and that can be an option as well. You just need to also be aware that people can get cavernoma after getting radiation. So it's a little, there's some subtlety there.
Okay, so regarding about the treatment of the brain AVM, you mentioned about the AREP trials. So in practice of treatment, do you suggest or prefer doing the interventional embolization in unruptured AVM, or just leave it there? No need.
Yeah, I think until we have, there are people working on this now. There are publications that are in development, and there have been some recent publications where people have suggested that maybe we overreacted to Aruba. Maybe we should be treating more of these AVM. But for an incidental unruptured AVM in my practice, I tell people, look, our literature suggests that you will do better if we just observe this. And unless, but I always do an angiogram to look at them, right? Because I want to make sure that there's not there's not some small aneurysm or something like that, which would certainly put them at a higher risk for bleeding. And in those cases, I would try to treat the high risk feature.
So if the patient have just only the symptom, for example, epilepsies, do you treat it?
Well, yeah. So if they're symptomatic, right? So if they have seizures or epilepsy, and it could be localized to the AVM, then I think you've got a reason to treat, particularly if the seizures are disabling, right? So if they're refractory to obviously taking seizure medications is going to be less risky for a patient than doing an intervention. So I always want to do what's going to give the patient. I think about these things in terms of disease modification or modifying the natural history of the disease, right? So if rather than trying to get some kind of angiographic cure, how can we just give the patient more symptom-free survival, right? And so if the patient can take seizure medications and do just fine, then that's what they should do. But if they're having seizures that are refractory and they're not getting better, or they're unable to control them, and then we can localize that seizure focus to the AVM, then certainly that would be a reason to treat.
Okay, regarding to your first case, you treat the dural AVF, the dural fistula. You inject a lot of onyx and very nice cast via the occipital branch. But I myself see it's very difficult to inject the onyx via the occipital. Do you have any tips and tricks in this case that you can fill in? Because most of the time
Yeah.
it can.
Yeah, I think that so. One of the things that can help you is using an intermediate catheter. So using a, like a 5 French, usually these are 6 French systems, right? So if you can use a 5 French intermediate catheter or something smaller to help you get closer. So the closer you can get to the fistula itself, the more chance you have for success. And then in that case, I used a balloon catheter as well. So I used a scepter.
Is this a breast cooker technique?
Pardon?
Is this a breast cooker technique? Pressure cooker
Sort of,
technique?
yes, right. So basically you're, just balloon occlusion, proximal balloon occlusion. In those case, like in that case, I think if I were to use, a regular microcatheter, probably I would have gotten a lot of reflux back and not gotten material to go forward into the fistula. But if you can get a balloon there, then you got a good chance.
Okay. The next question is about the diagnosis of the DAVF. Should we always suspect it when we see the transradial sinus visible on MRIs, non-contrast? What is other different diagnosis?
So help me understand. So if you see, I don't know if I understood the question.
If we see the transverse sinus signal on for example, on the T2, on the MRI non-contrast, should we suspect about the high flow in the transverse sinus and about the dural?
Yeah. The other differential would be, artifact, right? So if so the sinuses, they make turns, right?
Yeah.
So if you have if the patient is not symmetrically within the scanner, and on one side you've got flowing blood going in and out of the imaged plane quickly, and all you're going to see is a flow void, right? But if a patient is tilted just right so that on one side you're seeing the perpendicular flow, but on the other side you're seeing some parallel flow, well, that could give you could produce signal, right? Or if there's a venous stenosis that's slowing flow down, right? And venous stenosis can produce pulsatile tinnitus as well, right? So if you see a venous stenosis and then there's some signal some high signal within the sinus, that certainly could be, a differential. The other thing could be dural venous thrombosis, right? So the first thing you should think about anytime you see a non-contrast study with, what appears to be bright signal in the sinus, the first thing that you should think about is a dural venous sinus thrombosis.
Okay. Thanks. So regarding to your final case in the morning, is this a CCF? Is this a direct fistula between the carotid and the cavernous sinus? Normally, we see so many cases in Asia due to the trauma or due to the motorcycle accident.
Yeah.
But in your case, I don't know what is the reason. Is this the rupture of
I
the
think this,
aneurysm?
this was an odd case. I think this patient probably had a connective tissue problem, a connective tissue disorder, and I think that there was probably a cavernous carotid aneurysm that ruptured.
Mm.
That was a
And
really difficult case. That it was the ones that are I couldn't. I tried to treat it transvenous. I tried to treat it transarterial, and the issue with doing a venous, treating the venous side is when you have these really acute CCF, at least in my experience, is that they haven't had a chance to mature. So there are a lot of septae within the cavernous sinus, and I just couldn't get the coils to go into it. Yeah, and that was a hard case.
Yeah, and how about the stent? You use a flow diverter? Is this?
Yes, and that didn't work. And so then we used another off-label. So this is off-label. So I'm not promoting this at all. It's a covered coronary stent called a papyrus. And there are some people using those. There's some literature out there. It is not easy to do. That device does not navigate very well in the carotid. So it was tricky.
Yeah. Okay. So thank you so much, Professor Patrick Brown. I think your presentation is very nice and the discussion is very interesting. So I think there is no more question at the moment. So I will put it back to the Dr. Chepening. Yes. Thank you so much.
Thanks so much.
Yeah. See you.
Thank you, Dr. Brown. Thank you. And thank you, Dr. Win. I'm going to do a little housekeeping here a little bit okay, let me share my screen with you. Okay, please bear with me for 2 minutes. Do you see my screen yet? Yes?
Yes.
Okay, it's a PowerPoint. So anyone would like to listen to Dr. Brown again for the spinal cord AVM? If you do, say yes in the box. So I can arrange that to happen sometime in the future. And this is again the points of contact here. If you have any IT issue, the broadcast, the certification, please email this AREP capital letter 2025.it@gmail.com. And for educational and the topics, please email Dr. Wint at thaiwint@gmail.com. Any topics you want to listen to, please email her. So next year we will make it happen. And for membership, anything about the member, being a member or how it works, contact Dr. Kinley from Bhutan, and his email is kinleysangye@1323@gmail.com. And anything else, you can email me or if you don't know this question who you want to email to, just email me and I can direct you to the right person. And our next talk will be imaging approach to brain tumor. This will be from Dr. Samora from UNC Chapel Hill, University of North Carolina in Chapel Hill. He was our speaker last year too. His talk is really, really good. And I hope to see you all again on the next Sunday, first Sunday of March. And for the recording lecture, we are working on it. So we're gonna have IT team do editing, and then we'll make an announcement when it is ready to everyone here. So you can go in and look at it on the YouTube channel. It's gonna be our own YouTube channel. All right, I think that's all for me for today. I'm gonna go back here and then now we can end our webinar. So thank you everyone for joining us today, and I hope to see you again next week. I will try to make the spinal cord AVM happen sometime in the future, but we have to find good time for Dr. Brown and for us to set up the date. We'll keep you posted. Thank you.